So here is our general agenda. I typically use the first 15 minutes to ask if you have questions, and we review some of the important topics. And then I'll give the lecture on ethics in research and practice, how to deal with human subjects for grant proposals, and what the Institutional Review Board means. Some of you have undoubtedly come across these topics before, but today we'll talk about them in the context of the grant proposals that you're working on. And as you proceed to the workforce, many of the preceptors presented saying that grant writing is one of the major obligations for their agencies. And then we spend the last part of the lecture talking about the poster. It doesn't have to take us this long, so it depends on how quickly we proceed. Are there any questions based on previous discussions? Your assignments, grading, life in general. Okay, one of the important things to cultivate as a public health professional, researcher, student, is to pay attention to what's current, because public health cannot afford to be trailing the events. We always have to be at the forefront, which is why modeling is an important part of public health. Predictions, forecasting, those are all ways we protect the health of the public. So what I thought we'll do today, last week we heard a presentation by somebody who's an expert at the Alzheimer's Association, and it was a very well put together organization, and they support a lot of people. One of the biggest issues in society, as the pyramid of demographic pattern narrows at the top, is that we'll be able to prepare for a lot of elderly people. And one of the diseases that will become much more important are the diseases of the elderly, like Alzheimer's, within the dementia category. And we already saw a lot of the chronic diseases, such as cancers, becoming one of the biggest burdens for society. So I'd like you to cultivate this. Every day I go to Google News and I type in public health, or if I'm interested in a research topic, I type that topic into just to see what's going on in the world on that day. And there always is something on the topic that you might pick. So if you haven't done it, I didn't want to warn you ahead of time, because I will ask you now to tell us what happened in the last week on a topic of your practicum site that you can share with the class. So let's go down this list, and I know a lot of people who may not be here will not get this point. But if you're here simply, and if you don't know, you can't think of anything, that's all right, but tell us again where you are. So let's begin. Brenda Aguirre? All right. You're at Children's Center. So what's new in public health for children this week?
I'm not sure. We kind of have like a curriculum like daily.
Yeah, but that's not going to be, remember when you did the first assignment about the op-ed article? You had to go to the newspapers and find something, and then you responded. Okay, so this is in general, not particularly about your site.
Oh, okay, just in
Anything that you saw in the news in the last week and a half or so about children's health. All right, tell us any news items, something that caught your attention this week, and I'll tell you how it's connected to children's health.
Well, I've been looking up a lot about information about the Obama healthcare
Uh-huh.
and how it's gonna impact, like the Riverside community. That's where, like, home is for me.
Right.
Yeah, so I've been, kind of going over, because right now there's a county hospital in Riverside that is not, I guess, continuing it's not meeting its goals in terms of like the services that they want to provide for the community. And I just wanted, I'm just interested in how the new Obamacare will further affect.
But how is that connected to children's health?
Well, I know that they don't have sufficient funds to provide for neglected children
Mm-hmm.
of the community.
So that will be a connection. So what occurred to me this week was the tornado in Oklahoma, right? And the early victims were children. There was a school with 7 children found drowned, I think, this morning, right? Now, as a public health practitioner, what do we think could prevent such things? That's how we think, because natural disasters are public health problems. And one of the things that I read was that the building of tornado shelters was delayed for some reason by the federal government, right? So part of it could be budget cuts. And so one of the ways that economic downturns affect public health is that we're not able to protect the most vulnerable members of our population. Does that make sense?
Yeah.
Yeah. So that's the kind of thinking I want you to cultivate, that when you read a news item, you connect it to something you're working on as a public health person. That allows you to think about a response. How could we prevent such things? Your example was okay about the healthcare reform and the community in Riverside, but since you're focusing on children, you might want to connect it a little bit more to that topic. Okay, thank you. Jenny Alvarez? Okay. What got your attention this week?
I think what caught my attention is that they're doing, at the hospital they have JACO, so it's like the Joint Commission Accreditation. So they really make sure, I guess, like in terms of like public health, it's just that the hospitals follow the safety standards, and that like it prevents like disease prevention or like spread.
Right. So you read that in the news, so that was partly, where is your practicum site?
Practicum site is Child Life.
Yeah.
And it was what I like experienced in the past week.
Okay. And when I hear what you just said, what occurred to me was more local news, right? So what's happening at the UCI Medical Center this week? They're on strike, right?
Yeah.
And why are they on strike?
I'm not I think, does it have to do with the patient care technicians?
Yeah, and partly, well, money is always involved. The nurses and the staff are not paid well, so there's a union negotiation. But their claim is also that the hospital is understaffed, which means that the issues of safety and quality of care is on the brink, and that's what the employees claim to be a problem.
And then I remember, I think a few weeks back, there was, like I think 1 or 2 nurses or patient care technicians outside, and they were saying that like the UCI Med Center was like a high status for MRSA related treatments,
Right.
and that a lot of them feel like they're overworked, and that when they want to take breaks, they kind of just tell them, well, you just have to deal with what you have.
The situation. Yeah, which is not something patients want to hear. So that's a very important part of public health, the quality of care and occupational issues involved. Thank you. Sheena, not here. Christelle, not here. Talene, not here. Rebecca, not here. Brianna.
Yeah.
Okay. what did you find out this week in the news that caught your attention related to your practicum site? So tell us your practicum site and something that you found in the news.
Okay, so I work at Vitality Corporate Services,
Mhm.
and they provide health and wellness programs for the corporate environment. And something from research, we actually have to do a lot of research while we're there. So something I read about, I guess I could talk about some of the projects we did, I guess, because it incorporated learning about stuff that's in the
Yeah.
media.
Okay.
So one of the things we had to do was talk about, we had to lead a stretch, a 15-minute stretch about different ways you could get up and move throughout the day, because when you sit all day long, it's not healthy for you. So we researched a lot about why sitting is not good for you. There's a lot of studies that were done that said they correlated sitting all day with more musculoskeletal pain and higher incidences of heart disease and people dying earlier from it. So it proved that sitting all day wasn't good for you. So what they suggested was to get up and move throughout the day, whether you're stretching or just walking around or doing something to get the blood flowing, so
Right.
that you're not, just sitting sedentary, because that's not the way our bodies were made. And so those are the types of things that Vitality focuses on, is getting you up and moving and doing things to better your health so that you can be healthy while you're working.
Okay, so you were going to connect that to the news.
Yeah, so the news is what I said about the research, how sitting all day isn't good for you, and
Right, but as Vitally actually adopted a training program based on, not on the research, but it's something that the organization is doing routinely
yeah,
in their wellness training program.
yeah, they wait, what do you ask?
Yeah, no, it's fine.
They have, they actually are just about to launch one of the programs at, actually two different programs at two different corporate sites. So, yeah.
Okay, there is a name for the disease, like when they warn people on airplanes, for example, when a blood clot forms
Yeah.
because you sit so long, and it travels and blocks one of the arteries, and
Yeah.
And it's a very serious condition. All right, thank you, Jeffrey. Not here, Revin.
Yes.
Okay, here. Thank you. So you just walked in. What we're doing is trying to cultivate the habit of looking in the news and finding something related to what you're working on as a public health professional. So in the last week and a half or so, week, 2 weeks, is there anything in the news that you've seen that is relevant to your practicum site? So you can tell us about your practicum site so we can start thinking about it with you, since it doesn't come to you right away.
Yeah.
Okay.
So this past week, we just had a paper day.
Mm-hmm.
So where the medical residents, the third year and the fourth years, they present their research topics or something that's been happening in their practice. And then also 3 of the older doctors, they also presented on their research as well. And he was talking about the vaginal mesh.
Mm-hmm.
So how that has been a controversial issue in the news on whether it's safe for women or not. He was talking about how there's like a lot of lawsuits out on the vaginal mesh because it's deteriorating and it's not actually functioning as long as it's supposed to.
Right.
So
Has there been anything in the news about that? And so this was to prevent what kinds of diseases, or is it pregnancy?
this is for stress urinary incontinence.
Okay. What I saw in the news, it's somewhat related, but not too closely. Today, a UCI research group in the Department of Chemistry found a way to diagnose prostate cancer from urine. But of course, they want to push the cost down to $10 from, I don't know, $1 million per trial. Anyway, so what you've been involved with in the past, in the recent time with your practicum is this research presentation. So it's research in general, but this particular topic interested you, which is the one you remembered.
Yes.
Okay, thank you. Paige, not here. Victoria. Christiana Chan. Okay, thank you.
I was also at Vitali Purchase Services, and
Vitali Services also? Okay, well,
yeah, so then she kind of explained there about
Yeah.
for health, but I guess relevant to the news, I think it's actually even connected to like the UCI Medical Center strike.
Mhm.
It's like a lot of them feel like they're not being, like they're overstaffed and like their health is like
suffering.
yeah,
Yeah,
suffering
they're,
as well.
they're,
So
yeah.
as we like really like bridge the gaps between like the upper management and like those workers as well, like I think that could really like benefit them.
Glad you paid attention. That's an important work stress and conditions, especially in a situation where somebody is working to improve the life of others. I'm employed by UCI, but when I hear such stories, I think we could do better, at least avoid a strike, but that's my personal opinion. Okay, thank you. Karen?
Oh, here.
Okay, sorry, yeah. Okay.
So I'm at the Anaheim Regional Medical Center,
Mhm.
and then I work I'm an intern for the utilization management department, and then it's basically, it consists of like discharge managers and case managers and social workers, so, but I'm actually under the case managers. So I guess their main job is to make sure that like length of stay is appropriate, to make sure that patients before they're discharged, they have everything they need, so there's no like delay in when it's time for them to leave. And I guess one of the big things that happened is I had to sit in a meeting with them, and with the program called Senior Serve, so it's the new transitional program at the hospital,
Mm-hmm.
and they recently got like a $5 million grant. So I guess a few of the hospitals around the OC area are doing this program too, and it's basically just to help like elderly patients transition out of the hospital better.
Okay, what was in the news?
In the news,
Yeah, about that you found.
um,
Anything about elderly?
honestly, I haven't found anything recent like about transitional programs, because it's kind of like a thing that's persisted throughout the years. But then I noticed, like when I was doing my essays and stuff like that, that a lot of the programs that are out there are transitional. They kind of focus just on like the Medicare population, just to try to like decrease like federal funds towards healthcare costs.
Right.
But now it's more towards like a vulnerable population.
That's always in the news, partly because we're an aging population, and the way whether it's Medicare or Medicaid is going to affect their ability to live longer by themselves is an important topic. And if you do Google News, you'll always find something about that. Okay, Devin, not here. Jeffrey, Tuong, Rochelle, Soha. Okay, Soha is here. Okay.
So something that has to do with war and public health.
War and public health, you said?
Yes.
Yes, because you're at, we can't hear you.
Center.
Okay?
And it's something that I've been keeping up with because I'm Lebanese, and with the war that's going on, not the war, the armed conflict that's going on in Syria, there's
Right.
more than like 1 million Syrian refugees. So it's just like how the Lebanese government is trying to accommodate and also provide health care.
Right.
You know, just like war really has detrimental effects on public health. And something that I read this week is how like the International Committee of the Red Cross is trying to fund like medical care to Syrian refugees that fled basically to Lebanon and other neighboring countries.
Yeah, that's been in the news. Luckily, attention is now focused on the refugees as opposed to whether it's chemical weapons, whether the U.S. is going to enter the war. We teach a course called War and Public Health by Pauline Lubens, and she's going to teach it again, I think, this summer. it's very, I mean, she was a journalist who was embedded in traveled to Iraq many times to document the impact of war on the population there, but also on the families of veterans who come back from the war. So it's going to be, it's always a fascinating course because she brings in people with first-hand experience, but it's always something that public health, preventing war is part of public health, although it takes many, many different dimensions in terms of academic work. Yeah.
I actually took the class last spring.
Oh, you did? So you know Pauline, yeah. Okay, well, recommend it. We want people to enroll this summer. Thank you. Jeffrey?
Can we go back to Seoul?
Oh, you were here. Okay.
Yeah.
So has, okay. All right.
Okay, so I intern at the AIDS Services Foundation,
Mm-hmm.
and so recently the President's Emergency Plan for AIDS Relief has been up for, it's going to expire at the end of this year.
Mhm.
So there's some debate over budget cuts to that, with the recent budget cuts in the federal government.
The sequester.
Right.
Okay.
Whether or not they're going to continue funding it.
Well, that's an important thing to pay attention to. And that's how you know what's going to affect your program, what grant proposals you might want to write. But paying attention to what's in the news is extremely important. Thank you. So I'm sorry, tell me your name again.
So,
Okay. And, okay. Jeffrey. Okay, not here. So there is Soha and Soham. So I got, yeah. So I got them, they sound the same when I pronounce them, but they're different. Okay, so Soham, okay. Belem Gomez, Andrew Ho, Tina Ho. Okay, Tina. I can't hear that. Infant and Toddler Center. Okay.
So I guess something that's been kind of in the news recently, is about the sudden infant death syndrome and how it's kind
SIDS.
of increasing.
Yeah. Decreasing or increasing? Increasing.
Yeah. And that's because when the baby sleeps, it sleeps you put it not on its back, but on its stomach or something.
Yeah.
And the baby's supposed to sleep on its back so it doesn't suffocate.
Right.
So I guess something we could do about that is educate moms because they don't know about it. And we could send little catalogs.
Yeah.
Catalogs home to the parents or something.
Yeah.
to inform them.
This is a very important topic where public health professionals have given different and sometimes conflicting information to parents. And one of our researchers, Professor Tim Bruckner, actually studied this. As it turns out, there are cultural differences in how people put their babies to bed. And SIDS is more common in African American populations for some reason. And they were thinking that putting a baby to sleep on their stomach or the side or their back, that it runs in families. If your mom tells you this is how you slept, you tend to want to pass that on to the next generation. But researchers have found different incidences of sudden infant death syndrome depending on different practices. And it was very difficult to recommend one approach to parents. But I think the slogan, so they created slogans, back to sleep, as probably the safest way to do this communication that's most effective, and that it works for everybody, even though for some cultures it's not something they naturally would do because they have all kinds of beliefs about how the baby should fall asleep. But it's interesting that it's not working since the incidence seems to be increasing. Okay, thank you, Joanna. Not here. Lydia? Okay, yeah, thank you.
I'm at the American Heart Association.
American Heart Association, okay.
And something recent that I found was that air pollution, noise pollution have both been seen that they might cause cardiovascular disease.
Right.
In the past, it's only been one of the variables independently, but now they're saying both together could increase due to the calcification of the thoracic aorta.
Mm-hmm.
And so they're trying to see, this was only a cross-sectional study, so they want to further continue it to see if it is.
So there was a news release about a new study, yeah. I think in the past, a lot of air pollution and health work was based on just particulate matter. And now they're beginning to look at the chemical properties of the particles and showing that some of those can have this kinds of effect directly as opposed to indirect, yeah, as opposed to indirect. So if you can't breathe, then they can trace the consequences to cardiovascular effect. But so there are many metals in particulate matter from automobile exhaust, for example, and some of those can have directly toxic effect on the cardiovascular system. So it's a very hot area of research. Some of our faculty, Jun Wu in particular, is working on this, and she's looking at cardiovascular impacts, but also reproductive outcomes. Okay, thank you. That's good. Okay, Shelley? Yeah. Hands for Africa. There's always something new out of Africa. What's in the news?
Well, not in the news, but just at our practicum site, we recently found out that we got approved for the grant and we got $7,500.
Congratulations. Who was the funding agency?
Jewish Teen Grant.
Uh-huh. That's good. But yeah, if you I'm sure your preceptor or somebody at the organization is constantly looking at the news about, part of what I saw in the news, and I see it almost every week, yeah, something about the atrocities committed in countries at war where the punishment for traitors is to essentially cut off their hands. But what I saw in the news 2 weeks ago, this was in Mali, I believe, where they claim that it is because of the Sharia law that if you steal, they cut off your hand. And there are many people who are resisting these kinds of law as opposed to the traditional, you get court appearance, you're sentenced to jail, but it's not clear that Sharia law prescribes this explicitly without any flexibility. So the extremists would always want to put those kinds of laws into practice. Now, for a public health person, it's a very tricky position to be because, one, you want to respect the local customs and religions, but when it has to do with something that directly impacts health, losing one's hand is not just not being able to perform certain tasks. In many of these countries, it's a lifelong sentence for not being able to provide food for yourself and the family, and the consequences are much more severe. So there's always been a debate in the public health community, besides the kind of work that you're doing, which is reacting to when it's already happened. How do you prevent the loss of hands, whether it's because of legal issues or because of war or occupational type work? So prevention is the trickiest part of this kind of work in terms of understanding cultural sensitivities, but being able to walk through it to educate people about alternatives, right? Okay, thank you. We did Nika. So that was Shelley, right? Nika Kanani, Prachi, Andrew, Seong, Kelly, Natasha. Okay.
My practical site is visual aid in Orange County, specifically the Healthcare for Consumer Alliance Center. And with the Affordable Care Act fully enacted in 2014, a lot of new brochures and briefs are being included in our outreach.
You're revising the old brochures? Is it?
We have a lot of older brochures. For example, we recently got rid of a lot of the healthy family stuff. That's no longer in place. We replaced it with new Affordable Care Act brochures
Right.
and pamphlets to give out during outreach.
So you have to pay attention to the timing of implementation of different parts of the act and keep up with the news. Okay, thank you. Helen, Karen Lee.
Oh, that was me.
Yeah.
I
You,
went.
you went? Why
My
did you go?
name.
I said another Karen. Okay.
Oh, okay.
So now I have to find that Karen and mark them absent. Okay, I'll do that. Yeah, I thought that wasn't you, but okay. Fabio. Blake. Okay, Blake is here.
So I'm at the Orange County Coastkeeper.
Coastkeeper.
We do a lot of like environmental work for the coastal region.
Right.
It's not really news in like the past week, but probably the past month. So this company wants to build a desalination plant on Huntington Beach.
It's always controversial. Yeah.
And like the technology that they're using is really old. So it's not, like compared to newer techniques, it's not very good for the environment.
Right.
It's just like a giant pipe in the ocean that just sucks in water. At the same time, it like sucks in all the wildlife.
Right.
And they also discharge like super salty water. So when it's really salty, like nothing can live. 'Cause it's
Right.
just too salty.
So who's against? Who? So it was in the news because there is opposition to this, I imagine.
Yeah, well, there's also like newer technology that the company doesn't want to use because it's
Expensive.
expensive.
Yeah. That's always controversial. And it's remarkable that in California we have not done much with this technology. And it's only a matter of time because there are many water sources that are drying up, the Colorado River, for example. And in other parts of, I think primarily in the Middle East, Israel, for example, South Africa, they have superior technology that works very well. It may be that Americans don't hold patents, so it's expensive to get that technology. But there are many different ways to do it. I'm sure there has to be pressure on this company to do it right, because in 10, 15 years we'll be complaining about the impacts. Great, thank you. Okay, Sarah, Jennifer, Cami.
Here.
Okay, Cami is here.
So I'm interning at the American Lung Association,
Mhm.
and one of the more recent things would be the smoke-free policy that's going to be implemented at UCI starting January 1st.
That's right.
2014.
We all got
So
emails.
the Smoke-Free Policy Task Force has been working on that for quite a while, ever since Chancellor Mark Udall
Yeah.
put out their call in 2012, and UCLA was the first in April. So we're following the footsteps of that, and it's kind of the big thing going on right now because it'll make the entire campus 100% smoke-free in all indoor and outdoor areas.
Right.
And I was actually at the Health and Safety Wellness Fair earlier this morning, and I talked to a few faculty members who had various opinions on it, so it'll be interesting how that pans out.
Yeah, I got the email also yesterday to comment on something. I didn't read it yet, but I think this is exciting for UCI, and many people have worked on this for many years, so we look forward to it. Thank you. Evelyn?
Here.
Okay.
I'm at the Anaheim Medical Center, it's a hospital,
Mm-hmm.
and they're trying to implement a computer service where
Right.
So like we call them, physicians are busy, so there's a lot of time lost there. So they're trying to implement that, and hopefully it'll be implemented in October.
Okay. Is there anything in the news about the electronic medical records that you found?
No, but a lot of hospitals are currently using that.
Yeah, it's always in the news because the federal government is investing billions of dollars. And Kaiser, I think, is one of the leading hospitals around here who have this already. And UCI Medical Center, they hired somebody, we're working on it, but it's a very complicated thing to implement, very expensive, but a lot of people think it'll pay off in the end in terms of quality of care. So there are many models competing for which one is the best for each hospital to adopt. And that's always something that hospital administrators have to care about. Okay, thank you. Jennifer? I skipped you. Tell me your name.
Jennifer, no.
Okay, so you're not Jennifer, you're Jennifer Nguyen?
No, and you?
Okay. I called you or did not call you? What's your last name begin with?
NGO.
Oh yeah, okay, so you didn't go then, okay? All right, tell us.
So I was on behalf of the American Cancer Foundation, and the organization was established to kind of address the different barriers that are preventing the Vietnamese community from gaining like healthcare services to help them prevent cancer
Mm-hmm.
or to help them be aware of cancer and stuff. So like the different barriers are language and culture barriers. So our organization helps out with like providing services to help them like understand the healthcare system and to help them out like, and then also with like breast cancer screening and stuff like that. So yeah.
All right, did you find anything related to cancer or Vietnamese health in the news recently?
No, I haven't.
Yeah, I found something about, it's not about Vietnamese immigrants, it's about the relationship between those who are exposed to the herbicide Agent Orange during the Vietnam War and the kinds of cancers that they're beginning to find in the population. And the US government accepted responsibility for those kinds of health impacts, even after denying it for many, many years that there's any relationship. So that's a subject of research for people trying to link the toxic effects to health, but having a population of exposed people that took so many years to show any kind of significant, statistically significant effects. Some of those who may have immigrated to the US would be important to study them, right? I'm sure people are studying that, but I don't know. All right, thank you. So Jennifer Nguyen is not here. Lena Nguyen, not here. William O? Yeah, okay.
I'm at the Lighthouse Community Center, and it's an after-school organization.
Mm-hmm.
For students, and also like ESL programs for adults. And I don't think I've really found anything in the news for after school.
Okay, what about language? Because if one of the key things they do is education, English is a second language for this population.
It's mostly in Hispanic.
Right. So typically how you go about defining your topic, what you're interested in, what you want to be following, is to kind of pick one key point and see how that evolves in the news over time. Because I'm sure you'll find a lot about immigration, the Latino population, foreign language, skills. What I found recently, because I follow occupational health issues, are still poisonings that happen as a result of people not being able to read labels for pesticides accurately. It's difficult to know how to relate to that population. I mean, typically you hold the employer responsible, but if these are daily workers, you know, they come in the morning, they get paid by the hour, and then they leave, and it's another set of workers the following day. When they get sick, they don't go back to the employer. So it's very difficult to track how they got exposed and whether or not there was enough information or that they could read what they were doing in terms of the application of potentially dangerous chemicals. So, I mean, there are many, many issues involved with this, but to some extent, developing programs about training, even when people are undocumented, I think is one of the ways that public health advocates want to avoid emergency room visits because of this kinds of situation. Okay, thank you. So, Kevin?
Yeah.
Okay.
Nothing really. Well, I meant Be the Match, the national.
Be the Match. Okay.
There's nothing. I haven't really seen anything in the news about it, but I know they had their national or their regional managers meeting last week, and I'm pretty sure they talked about how our numbers are still pretty low in minorities.
So this is bone marrow transplant donation.
Yeah.
Okay.
Yeah, donations. Just mainly registering people to sign
Right.
up to be donors, and just that our numbers are still low, especially in male minorities. So just figuring out ways to get that.
Right.
Increase numbers there.
Right. I did see a story about a young boy with leukemia recently, but that's always justification to support the kinds of programs that the Be the Match does. And there was a young woman who graduated from Cal State Long Beach who essentially saved her sister's life many years ago, and this was a big celebration. Thank you. John? Okay. Nina? Wayne? Jessica? Lynn? Kathleen?
Here.
Kathleen is here. Who?
Here.
Kathleen. Okay, thank you.
Pam.
Yes.
I'm also interning at the Vietnamese American Cancer Foundation.
Mm-hmm.
And recently, I didn't directly go to the meeting myself, but my director went to the Affordable Care Act
Yeah.
meeting, and they were going over how, well, for our services, we provide services majority for people who are uninsured and underserved in our Vietnamese community. And so I was talking to the director of how the Affordable Care Act would, whether it would make an impact in our community or not. Because from my understanding, the pre-existing condition insurance is going to no longer be existing.
Right. It's no longer a reason to deny insurance.
Right.
Yeah.
So with the Affordable Care Act, from my understanding, there's quite a bit of restrictions of like who's qualified for it. A lot of our clients are like new immigrants and they don't speak English language, so they don't understand what they are qualified for, what they're not qualified for. And also, I believe the Affordable Care Act only applies to people who have been like are citizens of the United States and also have been like residents for a certain number of years. So that moves out a lot of our clients who have not been
Right.
in America for that amount of years, so they're not qualified for that. So it's a matter of like educating our clients and patients of the Affordable Care Act and how that would benefit them within their Vietnamese language, so they can understand.
Yeah. It's always a safe bet to talk about the Affordable Care Act because it's in the news every day. But in terms of how it applies to immigrant populations or even populations that have been here a long time but with special needs, it's not entirely clear how to deliver those services, especially the part where it requires that everybody has a medical home and especially in terms of prevention. Typically, people don't go to the hospital unless they're sick, but the idea in the Affordable Care Act is that you have a medical home where there's also a lot of preventive care that takes place to reduce cost of illness. But it's not clear how that will be implemented in Orange County for a lot of people who either don't have insurance or don't typically go to the hospital unless something serious happens. Okay, thank you. Nagme, Alexandra, Natalie, Tara, Alicia.
Here.
Good. 1 in 5, that's good. Okay.
I work at the American Heart Association, and Fox News had an interesting story the other day about how popcorn can increase your risk for
Popcorn.
cardiovascular disease.
Oh gosh.
It was a little misleading title, but here's what they said. There were researchers from West Virginia University. They published a study where they compared PFOA serum levels in different types of people and found that people who had a higher level of that had higher incidence of cardiovascular disease regardless of their age or sex or anything like that. And PFOA can be found in non-stick cookwares
Right.
and popcorn bags. So that's where the title
It's a very interesting finding. Thank you for sharing that. So perfluorooctanoic acid is PFOA, and it's made by DuPont. And there has been a long process of trying to get that chemical out of cookware. I didn't know it in the popcorn bags, but now it makes sense. It's essentially what they put in Teflon. It's the material that Teflon is made of. And one of our professors, Scott Bartell, has a very large study of groundwater polluted by PFOA under the DuPont factory in Delaware. But it's extended almost all around the eastern seaboard, Washington, D.C. area. And so they're looking at people who've been drinking that groundwater for many, many years and seeing what kinds of health effects that they may have. This group in West Virginia may be part of that, I am not sure, but it's a collaboration among many universities, and Scott Bartell is UCI representative on the grant. Okay, thank you. Suraj?
Here.
Thank you.
So I intern at the AIDS Services Foundation. So one of the things I was just researching was just the application of using like mobile technology to record data on HIV and AIDS.
Right.
And it's actually been shown to be really promising just because you can update results in real time. And more interestingly is that the fact that there's actually like the data consistency is not compromised. And it's shown to be just as accurate as like regular like signature.
Yeah. So this is for diagnosis.
Yeah.
Yeah.
Like for diagnosis or just like being able to fill in like a survey or something like that.
Yeah.
So it was pretty interesting just because like there's a shift towards using more mobile technologies
Right.
to collect data. So it's interesting just because like it kind of shows like where public health like information systems will be at.
Absolutely. Last Saturday at the Undergraduate Research Opportunity Symposium, I have 2 students who work with me and Professor William Tang in biomedical engineering. One of the groups, they're working on microfluidics for HIV diagnosis, but it will be something that you can attach to a mobile phone, and when in a drop of blood it changes color after about an hour, then you can transmit the data automatically to a healthcare provider or to some clearing agency where part of the problem is we don't have, especially in parts of Africa, Asia, they went to Peru to try this out in terms of understanding how it will be used. One of the problems is that in places where there is a lot of stigma, it's very difficult to get people to go to a facility to go get tested. So if you can sell them these kits, they can do it at home and then send the results to their healthcare provider. That will be a lot of benefit in terms of keeping track of who's infected and who's not, which is one of the reasons we haven't been able to curtail the disease, actually.
I was reading about it, but they were saying even in like Africa, even like in the most like rural areas, they were saying around like 35 to like 50% of the population still has access to cell
Oh yeah, it's become actually a lot more than that now. In the last 10 years, for many countries, it's now up to 80%, even in the rural population. But they don't do it the same way here. They buy the minutes with a little card that you put in the phone, and so it's just like buying any commodity without the bills and stuff. So it makes a lot of sense, and it works because the old system was telephone lines, which are never reliable. Rainfall, whatever, the lines get down for months. Nobody repairs it. But mobile phone changed everything in terms of communication, and public health is trying to build on that to deliver care. Okay, thank you. Emily? Neha? Jaskaran? Okay.
Okay, so I work at Transfer Economics, the HIV/AIDS agency, and there was a guest presentation yesterday by a doctor, HIV specialist doctor. He was talking about herpes and HIV, and what he said was that if you have herpes, then you have more chance of getting HIV.
Right.
And he also said that women have more they have more cases of herpes because herpes don't, they don't get transferred by fluids or blood. It's just, by weapon. So it's more chances that women will be getting HIV.
Yeah, I mean, it's when active herpes or herpes reduces the immune response, but also when it's active, there are lesions that allow the HIV to come in. But this is interesting. I don't know that comorbidity has been studied as well. We typically hear about comorbidity of HIV and tuberculosis, but not this other virus that was, if you all remember, you don't remember because this was in the 70s, herpes had the same kind of stigma and importance for the research community and public health as HIV has now. There was no cure. A lot of people were not sure how it was transmitted. And in many cases, it created a lot of interpersonal conflict in terms of people will advertise about, they're looking for somebody to marry, but that person has to have herpes because they formed their own social group. Very similar to HIV today. But then HIV came and we no longer heard about herpes until these comorbidity studies.
Yeah, he also said that herpes is prevented but not cured.
Yeah. Definitely preventable with the same kinds of hygiene methods that public health has done for a long time. Okay, thank you, Kiara. Shamli. Okay, Shamili, sorry.
So I intern at the Community Alliance Network, and they offer interventions and health education programs for people with drug abuse issues. And so something that I had to do last week was research statistics for underage drinking in Orange County. And I found out that Orange County is actually one of the worst cities in California that has the highest amount of
Underage,
alcoholic related crashes. So that's something that I found, and I didn't know that before. And compared to Irvine, the cities that were worse were Laguna Hills and Fullerton. And Fullerton, they think it's because Cal State Fullerton's there, it's a big
College town.
But compared to Irvine, which is also a college community, Fullerton is the worst.
Okay, thank you. So did you see anything like in the national news about underage drinking or drug use that caught your attention?
I wasn't looking at
You weren't looking, yeah.
So yeah, I don't know.
Just to look. There's always some disaster because somebody drank too much and started driving. But there's so many news like that. Okay, thank you. Cecil? Samuel? Yolanda? Samuel's here. I thought so. Okay.
I interning at Goodwill Support Employment Department. So they help like people with mental disabilities. I mean, Goodwill as a whole does this, but our department specifically helps like people with mental disabilities get employment. Like, and sometimes they put them in groups or just as an individual.
Mm-hmm.
They'll help them get a job at Goodwill or at like a normal workplace, and they'll work with people who don't have disabilities. Something, I mean, I saw this on TV. I thought it was interesting. I was watching, I don't know, I watched Apprentice with Donald Trump and stuff. So like one of the contestants on the show was playing Gillette, like he's a magician. He was I don't know if you're familiar with the show Apprentice.
No, I don't. I know it. I haven't watched it,
Well,
but yeah.
this series, they all run for charities,
Right.
like for the celebrities, and one of the celebrities' charity was, I guess I didn't look into it a lot, but it was a similar type of organization where they help people with mental disabilities
To get jobs. Yeah.
get jobs. But it was a very local charity though in like Las Vegas called Opportunity Village. And I looked into it a little bit, but it looks like well, that's what they do to help mental disability people who have mental disabilities get jobs. But I guess I'll ask my faculty.
Yeah. No, that's interesting. So I go to Goodwill to collect electronic waste samples because I do research on it. And the last time I went was about a month ago, and there were mentally disabled people doing the processing, right? So I was a little bit curious about protective gear. I mean, they wear gloves and things, but in terms of the toxic chemicals that they are potentially exposed to, I wanted to make sure that they understood the risks. But of course, it's not possible. How do you communicate risk to somebody who may not understand that? And I remember not even thinking about the public health implications. I wanted, because two of them helped us a lot, and I wanted to take my picture with them saying, thank you. And then the supervisor said, no, I can't do that because then they can't give consent, that they have to go home. And then I started thinking about how they gave consent. I mean, I know it's a good thing to get them to work. I just was worried about their understanding of the risk in that particular situation. And I told the supervisor that, but I'm pretty sure, I mean, I have a lot of respect for Goodwill, but it was a little concerning to me that if you're doing good, you want to avoid any kind of potential.
I know they had also one of the work sites, there was a risk like with carrying a lot of heavy stuff, and they pulled them out of there after.
Yeah.
But I don't know, I have to.
A lot of it will be trial and error, but hopefully it doesn't cause damage before it's fixed. Okay, Yolanda, thank you. Cynthia, Andrew, Elizabeth, Gloria Yi, Weisha Zhao. All right, thank you. Extra credit for everybody. So one of the things I wanted to talk about today, many of you are writing grant proposals that may include some uncertainty about what's ethically appropriate. The last case study we just talked about, the ethics of putting mental health workers in a situation, mentally disabled people into a situation where they may not fully understand the risk, is a public health ethics topic. And sometimes we're not sure how to proceed, and so we consult with philosophers, yes?
For those that can't give consent, is assent
Yeah, it's like the same with children. Nobody under 18 can give consent, but their parents can. So if there's a legal guardian, they give consent. But that assumes the legal guardian also understands the risks. Yeah.
So if they're mentally disabled and they're older than 18, are they still given an assent form?
Yes, they still have to have somebody that understands it. The other ethical issue, and which applies in many of your grant proposals, is if you are recruiting human subjects to help you with your research, usually you say you're going to give them some money or gift card. Sometimes it's $5, $10. if they're donating blood or clippings of hair, it might be up to $100. But if you tell somebody, I need to do your brain scan and I'm going to give you $10,000, okay, then the understanding of the risk has to be put in context about the reward and the coercion, because then you're coercing, because if they think, oh, $10,000, I can't make that much in a year, then they're going to take any risks to do it. So it's the same thing if you're employing somebody, okay, a mentally disabled person who could never get a job, and now suddenly they have work. So you're in a fine line between doing a good service and coercing them to take on risks that, so they'll sign, but it doesn't mean it's ethically appropriate. Okay. So there are many debates about where to draw the line in public health ethics. If you're interested in this topic more, you can click on any of these. University of Pittsburgh has a super course on ethics. The Association of Schools of Public Health has a whole page of documents on ethics in public health. The School of Public Health at UNC, University of North Carolina, Chapel Hill, they also have a course on public health ethics. It's like an online course you can take. And then the American Journal of Public Health, if you click on this, you'll come across research articles published since the journal has started more than 100 years ago on ethics up until the most recent issue of the journal. So there are lots of resources to pick one from. All right, so public health, we have two types of definitions of ethics. Okay, so we have what we call aspirational codes of ethics, and we have codes of conduct. All codes are helpful because they help us define the field. Okay, this is what public health cares about. When we make them accountable, that is their code of conduct, how you must do things, or if you break that code, there are penalties. They make agencies accountable for their actions. And so we can tell somebody it's illegal to sell cigarettes to somebody under 12, it's a 12-year-old. That's a code of conduct. And if an agency were to break that code, they are faced with penalties, and they could potentially even go to jail, because we don't think that a 12-year-old can make the decision to understand the risk of cancer when he or she is 50 years old. And so we make the agency accountable. The 12-year-old may have money, may have the wish, but the law says it's not ethical to do so, and it's illegal. Then codes also help create an ethical environment. So when everybody knows what the codes are, we see it in every place we look, it creates a situation where all of a sudden everybody kind of understands that this is not okay to do. It doesn't mean that the codes will always be that people will always abide by them, but it creates an environment of understanding of what's acceptable and what's not. But I also frame the discussion on ethical questions. We never are able to say, oh, we've finalized the code of ethics, because it moves as we increase our understanding, and it's different from culture to culture, from country to country. So one of the biggest differences, for example, in terms of public health ethics and how it helps us discuss funny questions, is that in California, for example, we are okay with certain kinds of stem cell research. Okay, we had to vote as a state to allow researchers to work on embryonic stem cells, whereas at the federal level, okay, NIH funds cannot be used for certain kinds of stem cell research because a lot of people in the country believe that it's unethical. Essentially, they think of it as using a potential life and destroying that potential life to help another life. And so some people draw the line there. But states can they can decide differently about what they'd like to do when the boundary is a little bit blurry and we're still questioning what's acceptable and what's not. So the difference between aspirational codes is that this is what we hope to accomplish with our ethical considerations. They are typically not legally enforceable, but they kind of give us a goal, whereas codes of conduct are always legally enforceable. Okay? We say, here is how you must behave if you work in this organization, and if you break that code, you're going to suffer the penalties. Aspirational codes don't have that legal framework around it. So in public health, we have certain fundamental aspirational codes, and I'm going to go through them. I think there are about 12 of them. So our aspirational code in public health is to address what we call fundamental causes. Why is this? Because if we don't know the cause of something, it's very difficult to do prevention. Okay? We need to be able to go to the roots of the problem to do prevention. Otherwise, we'll be giving people all kinds of information that may not pan out later. Okay? Today, we'd say, oh, eating fat is good for you. Tomorrow, no, it's carbohydrates. The other day, it's proteins. Because the field of the scientific investigation is changing, and we're not absolutely certain about the causality between these nutrients and the health outcomes. And so we lose the trust of the public. So as much as possible, we should always go for the fundamental cause. When we understand that, then we can do better prevention and eliminate those adverse health outcomes. So that's an aspirational code, which means we're not perfect. Sometimes we think we know the cause, and so we make the policy recommendation or the advice accordingly, and then 10 years later we have another brilliant discovery, and we realize that the cause that we thought was the ultimate cause was only a penultimate or proximate cause. We in public health also have an aspirational code about community health. We wish to achieve community health in a way that respects the rights of individuals in the community. Okay. So there are many ways where sometimes this creates controversy. Especially in the United States, what we believe to be the rights of individuals may not be good for the community. Can you give me an example of where we're currently having a debate about this?
Is it like something the right to property, like taking away your money, like taxes and stuff?
Well, make it more direct to public health, to mortality, morbidity, where individual rights versus
freedom.
Yeah, that's what it is. Yeah? So in the last week in the news, what can you think of? Actually, it's been the last month. Yeah.
So all the new policies in New York?
Well, yes, that's a big one. Mayor Bloomberg and his giant cup of soda. Okay. It's my right, to drink as much as but he says I can't buy it. So people feel, but he's going for this ethical approach that you do what's best for the community. But some individuals are claiming that it's stepping on their rights to drink or buy as much drink as possible. But the most serious debate is the right to own a firearm, a gun, right? And when you see the disasters as in a mentally disabled person having a gun and going to school and shooting up children, then you have to think about the community health issues. Okay? But the laws that Obama and some members of Congress have put in to try to implement a way to reduce firearm violence, apparently many believe is stepping on their individual rights. So as a public health person, what's the ethical the ethical dilemma is that we have to respect the rights of individuals, but to what extent do we do that? At what expense of the community health issues? Okay. So there is no clear answer, but the aspiration is that we push the community health to the extreme extent possible without compromising the rights of individuals. And sometimes it's very difficult to do because it depends on the country where you live. In the US, we're very committed to the rights of individuals, the rights of states. And sometimes the Affordable Care Act is debated about taking away the rights of states by imposing a federal policy on insurance, or taking away the rights of individuals. So this is usually very core to the debates we have in public health. And it's important to think about it in the context of what you're working on. Participation. We are collaborative, and there is something we call community-based participatory research in public health. So our policies, programs, and priorities should be developed and evaluated through processes that ensure an opportunity for input from community members. So it's not about imposing what we think is good for them. And you can pick these examples, Bloomberg's policies and the firearm policies, even in some places putting chlorine in drinking water or fluoride in drinking water is seen as impinging on their rights. They want to have a voice. They want the right to go drink other sources of water, which is part of why we import so much bottled water in this country. But we always have to hear the input of community members. That's not to say we make decisions that only agree with community members, but we have to have a process by which we take in that input and consider it seriously before we implement these policies and programs. And so the community participation is a very important part of public health. Okay. The fourth ethical consideration, the disenfranchised. And we talked a lot about this when we discussed maybe cultural or ethnic diversity, socioeconomic differences, but another word for disenfranchised is that they're almost always the most vulnerable to public health hazards. So whether they live at the edge of town, whether they live at the most vulnerable geographical locations, or crime-ridden, poverty-ridden, they don't have a political voice, they can't vote because they've been in jail once, or that they're minors. All these are reasons to pay particular attention to the conditions that are necessary for this disenfranchised population to be healthy. And so in research, if you're designing a research proposal, a study, you often think about how to oversample the disenfranchised. The National Institute of Health, for example, requires that for every grant that they fund, the proposal has to say how they're going to address whether they're recruiting human subjects, for example, how they address gender differences. It used to be that a lot of the discoveries we make in health care were done with male volunteers, okay, or male rats, and then we kind of extrapolate. Or we do it all with adults, and we don't think about children. Or we do it with just certain ethnic groups and not others. So now it's a requirement that your proposals have to address diversity of populations that may potentially benefit from the results. So not only in research, but also in practice, that we have to pay particular attention to this. Number 5, it's our ethical obligation to seek information. So we often have to do literature search. What's the current news? What's the current research on the topic? So if you write a proposal that has references dating back to 1980 and no current references, you're not at the top of the game. And it would be clear that you cannot possibly implement a policy or program that will address the current status of health. And so having up-to-date information is a critical part of public health ethics, and that means it has to be reflected in everything you write. It has to be obvious that you're basing your recommendations on the most current knowledge base. So we seek information, but we also have the ethical obligation to provide the information. So sharing information with communities is that they have that information for making decisions on policies or programs, and that we obtain the community's consent for the implementation of our program. So that's very, very important, especially the consent part. So providing them the information, we've talked about individual consent, but there are also ways where an individual does not represent a community. And how do you get the community's consent to implement a public health program? So there are certain communities where they say, oh, nobody asked us before they put fluoride in our water. And they want some kind of vote to show that they are supportive or against such intervention programs. So we do it democratically, either by voting, or if the community has a spokesperson, we walk through that person, but to make sure that they have the best information and they can provide their consent to act accordingly. Number 7, responsiveness. So when we have information, we can't sit on it. Within the resources available to us, we have to act based on the information. We have to be responsible, timely manner, and as thoroughly and effectively as possible. So there are many times when our government has been accused of not being responsive. So, for example, I see 1, 2, 3, 4, 5, 6, maybe plastic water bottles in the room. And for many years, we have had research suggesting that plastics with bisphenol A coatings can be toxic to people. The same thing with PFOA. We heard about that this afternoon. The Teflon works well, but there are indications that if you ingest a lot of it, it may be unhealthy. So why haven't we banned it, these chemicals? Okay? So in many, many lawsuits, individuals, advocacy organizations sue the federal government based on this principle that we're not responsive to the information gathered by researchers suggesting that these chemicals are poisoning the people and that we should ban them with the policy. Now, you can imagine that you're the head of the Environmental Protection Agency or the Food and Drug Administration, and of course you take this seriously. But you also have to think about the other ethical issues, about individual rights, about making sure you have community input, and those who might be against a new law banning such substances and the economic repercussions of eliminating a product that may be so popular and cheap that if you ban it, then people will no longer be able to afford either to eat well or to eat their popcorn, for example. So these are things that we weigh as we make decisions. Diversity. We've talked about this most of the quarter long. Public health programs and policies should incorporate a variety of approaches that anticipate and respect diverse values, beliefs, and cultures in the community. I think many of the speakers have really explained how they integrate this into their work, and it's important as you write your proposals to think about beyond the target population, does it include considerations for these diversity topics, values, beliefs, cultures that may be present, and skew the interpretation of the data. Enhancement of the environment. Public health programs and policies should be implemented in a manner that most enhances the physical and social environment. This seems obvious, but in many cases we also have difficulty ensuring that in fact what we're doing will not do damage to either of the physical or social environment. And we have to make sure that we think about these things before we proceed. Okay, confidentiality is one of the most important ethical concepts that we deal with in public health. If you're collecting data from people, either through hospitals or recruiting them yourself, you have to make sure that you have an opportunity to keep the information confidential because of the different ways that the information can be used to affect the well-being of those who have helped you in your work. So if there are exceptions to confidentiality, they must be justified on the basis of the high likelihood of significant harm to the individual or others. So in the news recently, I read typically this happens when somebody confesses a crime to a physician. And then the physician is kind of not sure how to proceed. But if somebody is mentally unstable, as in the shooting that took place in the movie theater, I think that was in Colorado, some other state. But and then somebody says, "Well, I'm going to go blow up a building." Confess that to their psychiatrist. The obligation of the psychiatrist is confidentiality. But then this consideration that others may be at harm means you have to call the FBI and say, my client or my patient is having thoughts. What if it's suicidal thoughts, just harm to themselves? The same thing. You have to take action that prevents that harm to individuals or others. Competence. This is about continuing education. We have an ethical obligation to become and maintain our competence in what we do. So if we are not current, we cannot provide the most effective service to the community. So not only individuals but institutions should ensure the professional competence of employees, and training programs are the way we do that. Then I think this is the last one. We're collaborative. We should engage in collaborations and affiliations in such a way that they build the public's trust and the institution's effectiveness. This is in part why we went through all of the core subjects and the cross-cutting themes, because there's hardly any topic in public health where you can solve with just one discipline or just one group of professionals. You can't avoid politics, you can't avoid economics, you cannot avoid religion and cultural institutions. All of these institutions have to engage with the healthcare community to deliver the most effective outcome. Okay, so those are the 12 aspirational codes in public health. Okay. And they are helpful, but as you can see, they sometimes conflict, and there are fine lines that we have to walk across to make sure that we balance one ethical aspiration with other issues that are perhaps more important in maintaining a population perspective on health. Research ethics, however, is not typically aspirational. There are codes of conduct. So we just left the aspirational codes, considering cultural, considering marginalized populations. Those are things we strive to do. Now, if we don't do them perfectly, we almost always are not held accountable or go to court or something. We may have to redo some things over. But when we're doing research, which is a privileged function, it's defined in the Code of Federal Regulation as a systematic investigation, including research development, testing, and evaluation that are designed to develop or contribute to the keyword generalizable knowledge. Okay, it's not a single case situation. Then we're engaged in research because the results of the research then can affect a large number of people. It's generalizable. So what does the federal government say about this code of ethics for research? In public health research, as some of you are writing in your proposals, it can include inanimate substances such as water, air quality, biological processes that do not involve humans. So you can be looking at mosquitoes and how they transmit malaria. But the questions typically involve humans because that's our role. And then, of course, there are research that are frankly about humans. Okay? And all of these involve ethical concerns, but a lot of the ethical issues we face are those that involve humans directly, because we're asking people questions, taking their samples, and the Code of Federal Regulations is very clear about what to do and what not to do. The most important that you will always hear is about informed consent. So if you have a survey or questionnaire in your proposal, this has to be part of what you write, okay? How do you recruit people who are informed about the participation in the study? So any potential study participant, it's a voluntary process. You cannot coerce people or force them to participate in research. And you have to be able to explain to them the risks and the benefits of the research in a way that's understandable to the participant. And it doesn't specify whether or not the benefits have to completely outweigh the risks and by how much. So the benefit may be the money you're giving them. Okay? If that way outweighs the risks, then it falls into what we discussed earlier, the category of coercion. So they minimize the risk because the benefits are so great. And sometimes, because it's research, we don't fully understand the risks. And occasionally, it turns out that the risk was not negligible after all. So if you were to give a questionnaire without appropriate consent, you're in violation of the Code of Federal Regulations on Research Conduct. And people have been sanctioned for that. They've lost their jobs, they've lost grants. I mean, the consequences are severe. And the worst is if somebody were to die as a result of that research, then liability means going to jail for that. And then keeping data confidential is important. So you have to write in your proposal how you will accomplish this. So confidential data are a data set containing information that identifies the study participant. So names, license numbers, pictures, those are identifying information, and you have to keep them confidential. Also information which the researchers are to conceal from others. So linking the identifying information with, for example, certain diseases they may or may not have will be something that violates confidentiality if you were to make that public. We also have what we call anonymous data. So one way to design your study so you're not worried about confidentiality, locking things in drawers and stuff, or passwords on computers, is that you collect anonymous data. So these are data or samples for which identifying information such as name, social security number, address are never collected, not maintained, and cannot be retrieved. So we call this unidentified. So there's no way to look at the data and trace it back to any particular person. Okay. When a data set has been made anonymous, so let's say we collected all of this, and then we deleted them in the record. Okay. We call this anonymized. Okay. So you can collect the data because it's good for your research, but before you use them, you make the data anonymous. They're unlinked. And that's also a way to protect it. But it has to be a permanent deletion of those identifying data. A third category is coded data. So when you collect the data set, you collect all of the identifiers, name, social security number. But instead of storing the information that way, you code. So you give participant number 1, number 2, number 3, and so that's what you show. You don't show the identifying records. But this means that somebody can have the key to the code. Okay? So very few researchers should have the access to the code that links the data sets to the smallest. So you make that code available to a very small number of people to protect the confidentiality. Because if a lot of people know how to go from the code to the identifiers, then the likelihood that somebody is going to make a mistake increases. So this is coded data that also protects the confidentiality of the record. In the informed consent paragraph that we showed, we also talked about explaining the risks and benefits to the participants. Risks may be any category that's experienced by the participant because of their participation in the research. It may be as simple as being embarrassed. You know, if somebody were to know that you're participating in a study where the recruits were, let's say there's an advertisement in the newspaper saying if you've ever suffered from some disease that we have stigma about, you know, herpes or mental health, you know, issues, a lot of people might want to participate, but wonder if their neighbor were to know that they went for that study, they fit the criteria of recruits, it could be an embarrassment. And so the researcher is responsible for explaining that as a risk before the participant is enrolled in the study. So that's part of the risks. Even though it's not physical health, it's just the possibility of embarrassment. Benefits may be if you're recruiting sick patients that they actually do get better or they are cured. But it may just be that they will contribute to improvement of knowledge, the betterment of society. Those are also things that you should explain to the participants. And you write that in your proposal to show that you understand some of the conditions that may bias your study. Okay, if you are recruiting people for whom, you know, this has no meaning whatsoever, and so it may attract certain types of people to the study just because this is what they want to do, and you eliminate as a bias people who this is not enough benefit to participate. So some of these things can bias a study in one way or another because what we call selection bias. So you're pulling from a group of participants who already are inclined to go one way or the other. You have to think about that when you interpret your data and think about it as you design your study. Okay, almost all our research fall under the category that involves humans. Okay, so in public health, proposals have to be reviewed by what we call the institutional review board before they even leave the institution. So UC Irvine, for example, has an institutional review board. So all proposals that are submitted to the NIH or foundations have to be reviewed by a committee of faculty to show that they abide by all of those ethical considerations that we just talked about. So if it's going to involve human subjects, it has to be reviewed by the board. It's also called the Human Subjects Review Committee, and this is specified in the Code of Federal Regulations. Every university, a lot of your foundations or public health agencies, if they write proposals to NIH, they have to have their own equivalent of the IRB. Hospitals have it. So UC Irvine, our IRB is under the Office of Research. And if you click on that link, you will be able to get to the Institutional Review Board for Irvine. But there are lots and lots of forms that need to be filled to submit to them along with your proposal, and they can give you feedback on the integrity of the work and the ethical issues that are involved. Now, for your proposals, okay, for your grant proposal writing, if you have human subjects at all, that is, you're not just working on water, air, with no relationship to humans. Okay. But if you have human subjects at all, you must include the category under which that proposal will be reviewed by the UC Irvine IRB. Okay? So we're now going to go through these categories. Exempt research, we use the term exempt. It doesn't mean it will not be reviewed by IRB, but it just means it's exempt from the regulations. After they've reviewed it, they've determined that it's exempt from the regulations. Okay? So exempt category are the kinds of research that either, as we discussed earlier, it's a collection of anonymous data, there's no identifier, or publicly available data, so it's already out there anyway, or conduct of the least potentially harmful research experiments. So some examples are, anonymous surveys. You're not asking people's names or telephone numbers or social security numbers. You are just observing people in public without collecting identifiers. When you're reviewing chats, hospital chats, retrospectively, that is, the patients have already left the hospital, but you're not going to publish their names. Or you're analyzing discarded pathological specimens without the patient identifiers. Now, this has become a little bit controversial. So we say passive observation. So it assumes that an individual, you're the researcher, you're sitting and you're writing your notes about how people are behaving in a public space. Okay? But what if you're taking a video of what's going on in a public space? You're allowed to do that, or you're taking pictures. Okay. The image of somebody is an identifier, right? So you cannot, beyond the human senses, what you can write down in your notes, okay? This is observation that doesn't record the permanent information about that person. But then you can ask, what if somebody is drawing, okay? What if you're a very good artist and you draw people in this room and somebody can come and say, oh, I know who that is. You can identify them, right? So there's a fine line here. If you're, especially in these days, and also publicly available data, you may have seen, for example, public health, we use this as a fair appeal strategy to keep people away from crystal meth. You've seen pictures of before and after, right? Those are allowed because the FBI takes the picture when somebody goes to jail, they take their mugshot, and over time, if that person is using drugs, you can show the differences, and we use it to warn people against drugs. But because it's public information, okay? Yeah, some of those people are recognizable, but it is public information, and you can use it in your research. But if it's something that's digital, that can go online, then you have to be very careful about that category. So your research can fall under exempt if it fits those definitions. It can also fall under this second category called expedited research. Expedited research is reviewed by the Institutional Review Board. It's typically when you are collecting samples and data in a manner that's not anonymous, which means you're collecting identifying information, and involves no more than minimal risk to subjects. So examples are you're collecting hair, saliva, dental plaque samples. You're collecting blood from healthy volunteers. If they're sick, it's not exempt, okay? Because that's more than minimal risk. Healthy subjects. You're analyzing video recordings, voice, not facial, okay? Studies of existing pathological specimens with patient identifiers. So their names, their addresses, social security number are associated with the specimen. So expedited means that they will be reviewed relatively quickly because the risks seem to be minimal. Okay? The third category is full committee review, meaning these are very serious consequences if something were to go wrong, and we typically, it takes about 1 to 2 months for your proposal to be reviewed by the board, and they are the kinds of research where you're collecting everything, the name, the disease, all of the information about the person and their outcome. You're still subject to keep all of those things confidential, and you have to have a plan for confidentiality. But here, it's a most rigorous level of review, and you have to state how you will protect the participants in the study. So if your grant proposal has human subjects, you must designate in your proposal writing, in the document you submit, whether it's exempt, expedited, or full review, based on your understanding of how you're recruiting patients and the risks involved to the patients, and how you're going to protect confidentiality of the records, and how you're going to get informed consent. Those things will be graded. Okay? Under the method section, you have to specify those things. Okay. Are there any questions about, yeah?
I have a couple questions.
Okay.
You said like for every association and foundation needs an IRB or equivalent. Like let's say, like I work at Goodwill, and like maybe one of the experts on this kind of program, and we wanted to do a research study or something like that. What would be the best way to do it?
Well, if you want to do a research study with human subjects,
yeah, I mean this, yeah.
and it's not a collaboration with a university,
And would that be the best way to do it?
usually they collaborate with the university with an existing IRB. But if you don't have that collaboration, you have to have your own IRB.
Okay.
And it has to be approved. It's a rigorous review process.
So
Yeah.
you would collaborate with PCI or a university, and then
Yeah, and get them to review the protocol and approve it.
and then the PI university?
Typically, yeah, typically.
And I have one other question.
Yeah, one more and then, yeah. Okay.
It's, like, what if you're like a company like Coca-Cola or something like that,
Mhm.
you're doing your own market study? That doesn't need any IRB or anything like that?
Oh, no. Yes, you can imagine Coca-Cola, they do a lot of research and testing on people, right? But they will have their own IRB. But there is also a process by which IRBs are not just made up of people within the company. So there's an external member of the board so that there is some vetting of what goes on. So they don't just approve things that are not ethically sound.
So even if it's not like for generalizable information, it's for their own.
Yeah, so that's a good point. I mean, I can do research that doesn't go through IRB. It will be unethical, but I can never publish it because as soon as I submit it for publication, the editors are going to ask, did this get IRB approval? And if you don't have it, you can't publish it. So that means if you have your own money, okay, this is a hole in the regulations. If you're a multi-millionaire, you fund your own research in your basement, okay? You don't have to go through this, but then you can never publish the results. So the question is, are companies like the tobacco company or the Coca-Cola, are they doing research that they never intend to publish, right? And so they violate all of these ethical things, right? There may be something in the legal codes outside of this system to make them responsible. So if something were to go wrong, let's say someone died while Coca-Cola is testing their stuff, right? Then that belongs in the criminal codes as opposed to a research code, because you'd have to explain, because the definition of research is this generalizable thing. Okay? But there are other activities that are similar but not technically research, according to the Code of Federal Regulations. Okay? Yeah.
Just for like human subject research, does that just include just like taking surveys off of like questions and asking them like
That's one kind. But human subject could also mean, so for example, a few years ago, I was interested in understanding whether or not people living in a rural part of Nigeria had too much lead exposure, which would explain some of the health issues we see. So I had to go collect blood samples from children under the age of 6. We collected from 300 of them at different schools. That's full committee review. So that's human subjects. It went through IRB. For various reasons, we're collecting blood. They're children, so we had to get consent from their parents. And we had to translate we had to give them a questionnaire, also we had to translate into a local language so that they can understand it. So it can go from anything, actually just observing people is human subjects research. It's just in the exempt category. Surveys and questionnaires where you're not collecting their names and stuff is exempt. But as soon as you're collecting their names, where they live, then it's expedited category. Okay. If they're healthy, that's still okay. But if they're sick, then you fall into the full committee review. It's about how risky it is for the participant.
Because I guess like this, we're using respondent-driven sampling.
Mm-hmm.
So it's like you're not actually going out there. You're using incentives to have people in the community find other people.
Yeah.
And so.
But they're still gonna feel. I mean, you can do human subject research. I've done it online. So we were trying to figure out what people know about the laws about what to do with their electronic waste. So we have about 4,000 people all over the country, but I've never met them. Okay, we put the consent form online, they type their responses online, and we collect the data. Okay? That's human subjects research too. So as long as people are involved and they have to give you something, then it's human subjects. And I mean, what you describe seems to fall under exempt, but it depends on what you're collecting from. Okay? Any other questions? Okay. All right, so I want to spend, I don't think we need to go to a break because I only have a couple of slides left, but the focus is on these proposals. I know the second draft is due soon, but then you have another chance for the final version. But the other assignment that we have to do, this course is really about the content in your writing. We assume that lower division writing tells you a lot about the grammar, construction, but here we want you to think about communication, writing in a public health perspective. So the content makes a big difference. And the three assignments, the op-ed, the scholarly review, the grant proposals, are really things you'll be doing regularly as public health professionals. The other thing you'll be doing is to presenting your work, your findings, to a variety of audiences in brief forms. So we communicate through conferences, seminars, interviews, and we give testimony in courts. These are ways that we make our work effective in the community. And this can be either you standing up in person, as many of our preceptors have done, with your PowerPoint slides and talking to people. When you do that, we want you to be clear, use legible fonts. The background should be clean. When you have too many things like leaves, and it just distracts from the content. It shouldn't be too busy, not too many words. This is almost too busy, but it's still legible. And you always try to provide opportunities for questions and discussion. So planning your presentation well is a very good strategy to learn. And it makes for, even when the content is not many, if it's one or two concepts you want to communicate, it makes it easy to do so. So what I sent to you yesterday is this. Because we have such a large enrollment, the easiest way is to not have everybody make 10 slides each, but that you produce something that can be either printed as a poster, or if you want to convert it to a slide PowerPoint presentation of 6 slides or so, it's still possible. But for the purposes of the class, this is what I'd like you to use. So I sent the template yesterday. It's already formatted. That is, the size of the poster is already formatted to the size that you would be able to present at a conference if you were to choose to do so. And typically, we fund some of our students who want to take this to conferences to actually print them out at FedEx. And they're typically something like 4 by 5 or 4 by 6 feet in dimension. So for the practicum, just to explain very briefly, keep this permanently. Your practicum agency logo, so in class we've seen the Alzheimer's Agency, the American Lung Association, the UCI Wellness. So just cut and paste their logo here. If you don't already have a title for your practicum project, you should have one. It should be brief and explanatory. Your name, your preceptor's name, and the address of the agency, okay, in the title panel. The abstract, I'd like you to talk about the mission of the agency. We've already talked about many of this in class. I put it up every time we have a guest speaker. At the beginning of the quarter, we went through everyone, and I asked you what your expectations are and what your responsibilities are, and then whether or not the expectations actually met reality and the results of whatever project that you did. And then here is most of what we focused on in the quarter. I'd like you to talk about the public health rationale of the project. So if it's a disease that they're working on, what are the epidemiological and statistics of the disease distribution in the population? So it could be cancer, it could be mental health, it could be attention deficit in children, it could be asthma for lung disease. And then we went through the core subjects: environmental health, health policy and management, social and behavioral science, and some key 2 or 3 up to 4 cross-cutting themes: communication, culture, leadership, professionalism, biology. These don't need to be long sentences, okay? Bullet points, the way I presented them here. Methods. What exactly did you do or the agency do to fulfill their mission? The specific contributions that you made during this period? What are the gaps in knowledge? Why haven't we solved this problem yet? And your thoughts on ways to improve the performance of the Practicum agency. If there are any figures, tables, or charts that you want to put, no more than 1 or 2 in this space, okay? And then the writing assignments, the title of your op-ed, and anything else you want to say about it, the title of your scholarly review and anything else you want to say, and the title summary of the grant proposal, name of the agency that you're submitting to, amount you're requesting, period, 1 year, 2 year, 3 year, 4 year, 5 years, that you expect the project to be completed. And then any references, citations, and acknowledgement. Was this clear? Because you can work on just one PowerPoint slide. But the dimensions are big, so you'd realize that the font, like this font is 66 font point size, okay? And this is about, I think, either 30 or 28. So, if you'd have to shrink the magnification so you can have it all in one page. But you can type everything in. Okay. All right, so the second draft of the grant proposal is due May 22nd. I'd like you to turn in the PowerPoint presentation May 30th next. And then we will do the presentations in the discussion session. So it would simply be a projection of that slide, right? And then you will have just 1 or 2 minutes to talk about it. Okay? So you just take us through.
We don't need to print this.
No, submit to the Dropbox, and then we'll compile them and project them for you. Okay, yeah.
The question that I just looked at, so that the grant proposal draft is due today at 11:59, but the syllabus says the 23rd.
Oh, it's tomorrow. I'm sorry. This was a typo. All the things are due on Thursday because I want us to have a time to discuss in class before. So that's 23rd. They are always Thursdays. Okay? See you next week.